Thank you so much, Courtney. Thank you everyone for joining us today. My name is Virgie Fields, and I'm a public health analyst with Lantana Consulting Group, supporting the NHSN Antimicrobial Use and Resistance module. I'll let my colleague Sho introduce herself.
Good morning, everyone. My name is Sho Wu. I am a medical epidemiologist with NHSN and team lead for the antimicrobial use and resistance team. Nice to meet you all.
Thanks, Sho. So today we'll be discussing the NHSN antimicrobial resistant, or AR, options, two newest metrics, the standardized resistant infection ratio, which is the SRIR, and the pathogen-specific standardized infection ratio, the pSIR. The NHSN AUR team will be monitoring the Q&A box for this session, and questions about the AR option, SRIR, and pSIR will have priority. The objectives for today's session are to describe the methods used to calculate the AR option, SRIR, and pSIR, run and interpret the SRIR and pSIR analysis reports, describe resources available to help facilities use the SRIR and pSIR for action, and describe possible explanations for high or low SRIR or pSIR values, understand how to differentiate among these possible reasons, and provide potential solutions. First, let's go into some background. CDC developed two new NHSN AR option benchmark metrics using 2019 as the baseline year. The reports became available to NHSN facility and group users in 2023. The two metrics are the SRIR, the standardized resistant infection ratio, and the pSIR, the pathogen-specific standardized infection ratio. Both are observed to predicted ratios, like the AU option standardized antimicrobial administration ratios, or the SARs, the standardized infection ratios, the SIRs, and the standardized utilization ratios, the SURs. Hospitals can compare their rates of hospital onset infections of specific AR phenotypes or pathogens to a national benchmark. For the SRIR, we're looking at infections of specific AR phenotypes, such as MRSA. For the pSIR, we're looking at infections of specific pathogens, such as Staphylococcus aureus. Health departments and systems can use the SRIR and pSIR to better understand these issues across and between facilities in their jurisdiction or health system. NHSN classifies AR events as hospital onset or community onset based on the specimen collection date and date of admission. If a specimen was collected in an inpatient location on or after day 4, where day 1 is the date of admission, then NHSN will classify the AR event as hospital onset. If a specimen was collected in an inpatient or outpatient location on days 1, 2, or 3, then NHSN will classify the AR event as community onset. SRIRs allow facilities to compare their number of observed resistant infections for eligible phenotypes to the number predicted based on 2019 baseline risk-adjusted AR models. To calculate the SRIR, we divide the number of observed resistant infections by the number of predicted resistant infections. Observed resistant infections are the number of resistant hospital onset isolates reported to NHSN for the following 7 phenotypes: carbapenem-resistant Enterobacterales, extended spectrum cephalosporin-resistant Enterobacterales, fluoroquinolone-resistant Enterobacterales, vancomycin-resistant Enterococcus, fluoroquinolone-resistant Pseudomonas aeruginosa, multi-drug-resistant Pseudomonas aeruginosa, and methicillin-resistant Staph aureus. Predicted resistant infections are the number of resistant hospital onset isolates for a particular phenotype predicted for a hospital based on negative binomial regression modeling applied to nationally aggregated 2019 AR data. Phenotype definitions can be found in Appendix I of the AUR module protocol linked here on this slide. I also listed the phenotype definitions here on this slide just for your reference. Facility-wide SRIRs can be calculated for 3 specimen sources: blood, urine, and lower respiratory tract. For a facility to calculate a SRIR, they must have reported at least 1 hospital onset isolate for the eligible organism from the correct specimen source during a specified time period of interest. For example, to generate a SRIR for 2022 Q3 vancomycin-resistant enterococcus in blood, the facility must report at least one hospital-onset enterococcus isolated from blood in July, August, or September of 2022. In addition, the facility must report yes to the applicable CLSI M100 breakpoints question in the specific year's NHSN Annual Hospital Survey. I'll go more into detail on that in later slides. pSIRs allow facilities to compare the number of observed infections for eligible pathogens to the number predicted based on 2019 baseline risk-adjusted AR models. To calculate the pSIR, we divide the number of observed infections by the number of predicted infections. Observed infections are the number of hospital onset isolates reported to NHSN for the following 4 eligible pathogens or pathogen groups: Enterobacterales, Enterococcus, Pseudomonas aeruginosa, and Staphylococcus aureus. Predicted infections are the number of hospital onset isolates for a particular pathogen or pathogen group predicted for a hospital based on negative binomial regression modeling applied to nationally aggregated 2019 AR option data. Just like the SRIRs, facility-wide pSIRs can be calculated for 3 specimen sources: blood, urine, and lower respiratory tract. For a facility to calculate a pSIR, they must have reported at least one hospital onset isolate, and that's any reportable pathogen, from the correct specimen source during the specified time period of interest. For example, to generate a pSIR for 2022 Q3 enterococcus in blood, the facility must report at least one hospital onset isolate from blood, that's any reportable pathogen, in July, August, or September of 2022. Now that we've gone through the background of the SRIRs and pSIRs, let's spend some time running and interpreting the SRIR and pSIR reports in NHSN. First, remember to generate datasets. Generating datasets is the first step to performing analysis in NHSN. Newly uploaded data do not appear in the NHSN analysis outputs until you generate new datasets. Once you generate datasets, click Analysis, then Reports, and then on the Analysis Reports page, click the Antimicrobial Use and Resistance Module folder, then click the Antimicrobial Resistance Data folder, and then the SRIR and the pSIR reports are the first 2 reports listed in the AR data folder. The default SRIR report has 21 SRIR tables. The default pSIR report has 12 pSIR tables. Reports default to facility quarter level and are also available at the half-year, year, and cumulative levels. Reports are not available by month. Facilities that report eligible AR option data can generate SRIRs and pSIRs for January 2019 forward. Let's walk through an example SRIR report. We will specifically look at the SRIR for hospital onset multi-drug resistant Pseudomonas aeruginosa and lower respiratory tract specimens. Please note that the following example uses fictitious data for illustrative purposes only. First, we'll click the SRIR report and select Modify Report to bring on the modification screen. On the modification screen, we select the Time Period tab. Let's say we want to look at this data reported for 2021 through 2023. I selected Summary Year as the date variable and put 2021 in the beginning box and 2023 in the ending box. I clicked the Show Descriptive Variable Names box at the top, indicated by the orange arrow, so that I can see the full variable names. I want to look at the SRIRs by year, so I go to the Display Options tab to select Summary Year for the Group By variable. Again, SRIRs are available by quarter, half year, year, and cumulative, and the default setting is by quarter. Please note that users do not have the option to generate rates or SRIRs by month. Based on our modifications, the output displays data for 2021, 2022, and 2023. All 21 SRIR tables were included in the output, so I scroll down to find the hospital onset multi-drug resistant Pseudomonas aeruginosa and lower respiratory tract specimens table. These 4 footnotes will be the same for all 21 tables. The carbapenem resistant Enterobacterales and extended spectrum cephalosporin resistant Enterobacterales tables will have an additional footnote about the breakpoints question in the NHSN Annual Hospital Survey. Now let's interpret each element of our modified report. The first column will display your NHSN Facility Organization ID. The second column will display the time period we selected on our modification screen. The report aggregated the data up to the summary year level with one row for each year. The title is displayed with a description of the phenotype and specimen source, which is multi-drug resistant Pseudomonas aeruginosa and lower respiratory tract specimens. The SRIR type column provides the abbreviation for this phenotype and specimen source, which is HO, MDR, PA, LRT. I have included the SRIR phenotype, the specimen source, and the abbreviation that will be included for the SRIR type in NHSN on the slide for your reference. Now looking at the resistant hospital onset isolates column, we can see that there were 7 hospital onset multi-drug resistant Pseudomonas aeruginosa reported from lower respiratory tract specimens in 2022. None were reported in 2021 or 2023. Now looking at the predicted resistant hospital onset isolates column, based on 2019 baseline risk-adjusted AR models, we predicted 1.081 hospital onset MDR Pseudomonas aeruginosa in lower respiratory tract isolates for 2021, 2.713 for 2022, and 0.296 for 2023. The patient days from the AR summary are pulled from the FACWID-N patient days that facilities submit monthly for the AR option. Patients contributed 25,759 patient days for all facility inpatient locations in 2021, 22,336 patient days in 2022, and 7,050 patient days in 2023. The SRIR, which is again the ratio of observed hospital onset resistant isolates to predicted resistant hospital onset isolates for hospital onset multi-drug resistant Pseudomonas aeruginosa and lower respiratory tract specimens, was 0 in 2021, 2.580 in 2022, and the SRIR was not generated for 2023. A few notes with interpreting the SRIR values. As a ratio, SRIR values are always greater than or equal to 0. Similar to SIRs, lower values are considered better. As for the interpretations, a SRIR value less than 1 indicates fewer resistant hospital onset infections were observed than predicted. A SRIR value equal to 1 indicates the number of observed resistant hospital onset infections were equivalent to the number predicted. A SRIR value greater than 1 indicates a greater number of resistant hospital onset infections were observed than predicted. SRIR equals 0 indicates the facility reported the hospital onset pathogen from the specimen source during the time period of interest, but the pathogen was not resistant to the drug specified. In our multi-drug resistant Pseudomonas aeruginosa and lower respiratory tract specimens example, the SRIR was 0 for 2021. This indicates that Pseudomonas aeruginosa was isolated from lower respiratory tract specimens in 2021, but none of those isolates met the definition for being multi-drug resistant. There are several situations where the SRIR could be missing or suppressed. The SRIR will be missing when there were no hospital onset pathogens of interest isolated from the specimen source of interest during the time period of interest. If the number of predicted resistant hospital onset isolates is less than 0.3, then the minimum precision criteria was not met and the SRIR will be suppressed. Additionally, SRIRs for carbapenem-resistant Enterobacterales and extended spectrum cephalosporin-resistant Enterobacterales will not generate for facilities that answered no to the applicable NHSN Annual Hospital Survey breakpoints questions, and more on that in a few slides. An example of the minimum precision criteria not being met. For 2023, the predicted hospital onset multi-drug resistant Pseudomonas aeruginosa and lower respiratory tract specimens was 0.0 0.296, which is less than 0.3. So the SRR, the SRR p-value, and the 95% confidence interval were all suppressed or appear missing in the report. The SRR p-value and the 95% confidence interval indicate if observed or reported resistant infections were statistically significantly different from predicted resistant infections. Users should interpret both p-values and 95% confidence intervals with caution, as statistical significance does not necessarily translate to clinical significance. For example, the number of observed multi-drug resistant Pseudomonas aeruginosa and lower respiratory tract specimens was significantly different from predicted in 2022, where the p-value was 0.028, but not in 2021, where the p-value was 0.339. And more about interpreting p-values, if the SRR p-value is less than or equal to 0.05, that indicates the number of reported resistant hospital onset infections is statistically significantly different, and that's greater or fewer, from the number of predicted resistant hospital onset infections. A SRR p-value greater than 0.05 indicates the number of reported resistant hospital onset infections is not statistically significantly different from the number of predicted resistant hospital onset infections. And then for the 95% confidence interval, if the confidence interval does not include 1, for example, if it's 0.85 to 0.92, the SRR is statistically significantly different than 1. Specifically, the number of reported resistant hospital onset infections is statistically significantly different from the number of predicted resistant hospital onset infections. And in turn, the p-value will be less than or equal to 0.05. If the 95% confidence interval does include 1, for example, 0.85 or 1.24, the SRR is not statistically significantly different than 1. Specifically, the number of reported resistant hospital onset infections is not statistically significantly different from the number of predicted resistant hospital onset infections, and the p-value will be greater than 0.05. The p-value and the 95% confidence interval will always indicate the same statistical significance, and users can interpret them interchangeably. So let's go back and discuss the NHSN annual survey breakpoint questions and how those affect the SRIRs. An SRIR will not generate for 2 phenotypes if outdated breakpoints were in use. So this was an exclusion decision made during the 2019 baseline modeling that we applied to the current SRIR report. A facility reported no to the annual hospital survey question has the laboratory implemented revised breakpoints recommended by CLSI for 3rd generation cephalosporin and monobactam, Estrionam, for example, breakpoints for Enterobacterales in 2010, predicted values and SRIRs for extended spectrum cephalosporin resistant Enterobacterales will not generate for that year. In addition, if a facility reported no to the annual hospital survey question, has the laboratory implemented revised breakpoints recommended by CLSI for carbapenem breakpoints for Enterobacterales in 2010, predicted values and SRIRs for carbapenem resistant Enterobacterales will not generate for that year. For example, this facility reported no to the 2021 annual hospital survey question regarding implementing revised carbapenem breakpoints for Enterobacterales in 2010. When the facility runs the SRIR report, data for 2021 in the SRIR tables will not display predicted resistant hospital onset isolates, the SRIR, the p-value, or the 95% confidence interval. These values will appear missing in the report. As mentioned earlier, the SRIR and extended spectrum cephalosporin resistant Enterobacterales tables will have this 5th footnote included. Let's walk through an example pSIR report now. We will specifically look at the pSIR for hospital onset Pseudomonas aeruginosa and lower respiratory tract specimens. Please note that the following example uses fictitious data for illustrative purposes only. So first, we'll click the pSIR report and select Modify Report to bring up the modification screen. On the modification screen, we select the time period tab. Let's say we want to look at the data reported for Q3 of 2021 through Q2 of 2023. I selected summary year quarter as the date variable and put 2021 Q3 in the beginning box and 2023 Q2 in the ending box. I want to look at rates or the pSIRs by quarter. So I go to the display options tab to select summary year quarter for the group by variable, which again is the default. Based on our modifications, the output displays the pSIRs for 2021 Q3 through 2023 Q2. All 12 pSIR tables were included in the output, so I scroll down to find the hospital onset Pseudomonas aeruginosa and lower respiratory tract specimens table. These 3 footnotes will be the same for all 12 tables. The Enterobacterales and Enterococcus tables will have an additional footnote listing the pathogens included in that pathogen group. The first column will display your NHSN facility organization ID. The second column will display the time period we selected on our modification screen. Each row in the report represents one quarter from 2021 Q3 to 2023 Q2. You'll notice that there is no 2023 Q2, even though we selected that quarter in the modification screen. No hospital onset isolates, the numerator, or patient days, denominator, were reported for April, May, or June 2023. So 2023 Q2 will not populate in that table. The title includes a description of the pathogen and specimen source. The pSIR type column provides the abbreviation for this pathogen and specimen source, which is HOPALRT. I have included the pSIR pathogen or pathogen group, specimen source, and the abbreviation that will be included for the pSIR type in NHSN on this slide for your reference. We can see that there were 4 hospital onset Pseudomonas aeruginosa reported from lower respiratory tract specimens in 2022 Q3 and 3 in 2022 Q4. None were reported in the other quarters in this time period. The pSIR model predicted 1.447 Pseudomonas aeruginosa in lower respiratory tract isolates for 2022 Q3 and 4.156 Pseudomonas aeruginosa in lower respiratory tract isolates for 2022 Q4. Patients contributed 4,361 patient days for all facility inpatient locations in 2022 Q3 and 12,525 patient days in 2022 Q4. The pSIR, which again is the ratio of observed hospital onset isolates to predicted hospital onset isolates, was 2.764 in 2022 Q3 and 0.722 in 2022 Q4. As a ratio, pSIR values are always greater than or equal to 0. Similar to SIRs, lower values are considered better. And for the interpretations, a pSIR value less than 1 indicates fewer hospital onset infections were observed than predicted. A pSIR value of equal to 1 indicates observed hospital onset infections were equivalent to the number predicted. And then a pSIR value greater than 1 indicates a greater number of hospital onset infections were observed than predicted. Using the example of Pseudomonas aeruginosa in lower respiratory tract specimens, a pSIR equaling 0 indicates a facility reported at least 1 lower respiratory tract specimen in 2023 Q1, but no Pseudomonas aeruginosa was isolated. There are a couple situations where the pSIR could be missing or suppressed. The pSIR will be missing when no positive culture grew reportable pathogens from the specimen source during a time period of interest. Take the example on this slide. For 2021 Q3, 2021 Q4, and 2022 Q1, even though the predicted hospital onset isolates were all greater than 0.3, no positive culture grew reportable pathogens from lower respiratory tract specimens during these quarters, so the pSIR will be suppressed or appear missing. If the number of predicted hospital onset isolates is less than 0.3, then the minimum precision criteria was not met and the pSIR will be suppressed. Looking at the pSIR p-value and the 95% confidence interval, the number of observed Pseudomonas aeruginosa and lower respiratory tract specimens was not significantly different from predicted in 2022 Q3, where the p-value was 0.0754, or 2022 Q4, where the p-value was 0.6197, all greater than 0.05. So similar to the SRIRs, you can interpret the p-value and the 95% confidence interval the same way. So if the p-value is less than or equal to 0.05, that indicates the number of reported hospital onset infections is statistically significantly different, greater or fewer, from the number of predicted hospital onset infections. A pSIR p-value greater than 0.05 indicates the number of reported hospital onset infections is not statistically significantly different from the number of predicted hospital onset infections. If the 95% confidence interval does not include one, the p-value will be less than or equal to 0.05, which indicates the number of reported hospital onset infections is statistically significantly different from the number of predicted hospital onset infections. If the 95% confidence interval does include one, the p-value will be greater than 0.05, which indicates the number of reported hospital onset infections is not statistically significantly different from the number of predicted hospital onset infections. Again, the p-value and the 95% confidence interval will always indicate the same statistical significance, and users can interpret them interchangeably. I'll now turn it over to Sho to discuss how to use the SRIR and the pSIR for action.
Yep, sure. So I'll go over how we can use SRIR and pSIR for action. Next slide. So first of all, we need to understand what the possible explanations are for high or low SRIR or pSIR. Besides inherent patient risks for infections, we can think of several factors that are actionable for hospitals. So these factors are first, data quality, then specimen collection practice, lab methods, infection control, and antimicrobial stewardship. Next, I will go over each one of these factors. So first, data quality. So we highly recommend reviewing your data quality prior to interpret any SRIR or pSIR results. This can be done by following the steps described in the NHSN AR option data validation protocol. Make sure, be aware that if any incomplete data from selective or cascade reporting were submitted to NHSN, it is possible that your SRIR is underestimated. Selective or cascade reporting is an antimicrobial stewardship strategy to guide appropriate antimicrobial use by limiting the antimicrobial susceptibility test results to prescribers. In other words, susceptibility results for some antibiotics were suppressed from prescribers' view. Using partially suppressed susceptibility data can bias your AR surveillance measures. It is important to extract AR data from an upstream data source and bypass selective and cascade reporting. We recommend checking the percent tested for the drug of interest using the AR antibiogram and percent tested report available on NHSN application. And if the percent tested is low for certain phenotypes, reach out to your IT and surveillance vendor for troubleshooting. In selective reporting, antimicrobial susceptibility testing or AST results for certain drugs are reported conditionally in your electronic health records. For example, fluoroquinolones results are only reported for adult patients, which means they are suppressed for pediatric patients. In this case, if partially suppressed data were submitted to NHSN. Since SRIR is calculated for all inpatient locations as a whole, also known as fact-Y-in, SRIR for fluoroquinolone-resistant Enterobacterales would be underestimated. Cascade reporting is a type of selective reporting where AST results of secondary antimicrobial agents are only reported if the isolate is resistant to primary agents. For example, cefepime results are only reported for isolates that are resistant to ceftriaxone. So in this case, since the isolate is susceptible to a drug with a narrower spectrum in the same class, it is likely to be also susceptible to cefepime. Therefore, in cascade reporting, SRIR is less likely to be impacted than which would be impacted by other types of selective reporting. Second, because AR option events are essentially positive cultures, the incidence of events can be biased if specimen collection practice deviate from standard of care. Examples include, but not limited to, collect urine cultures from urinary bag instead of from the port of catheter, or delaying transmission of urine cultures at room temperature, which results in overgrowth. Additionally, overuse or underuse of cultures can lead to overestimating or underestimating your SRIR or pSIRs. However, if cultures are overused in outpatient locations, because the risk adjustment for SRIR takes community onset prevalence into account, the SRIR for hospital onset resistant infections in inpatient locations are actually underestimated because of the overestimated community onset prevalence. Lab methods used to identify AR organisms and phenotypes is another factor that can potentially bias facility SRIR or pSIR. AR option currently captures events based on cultures. Therefore, SRIR could be underestimated if the AST for the antimicrobials that are required to determine SRIR phenotype is not routinely reported or is replaced by a culture-independent rapid diagnostics. We recommend checking the percentage of isolates tested for the drug required for the phenotype and reach out to your microbiology lab to understand lab methods used for organism ID and antimicrobial susceptibility testing. If a high SRIR or pSIR is not because of data quality, data suppression, culture practice, or lab methods, then we have to think why my facility has such a high incidence rate of hospital onset infection associated with specific organisms. We recommend conducting further investigations. For example, you can list out all the events of the phenotype or pathogens which have high SRIR or pSIR, and then clarify whether there is a shared source or infection. To determine clonality, consider a laboratory evaluation, such as whole genome sequencing. Also, we recommend reaching out to your health department's HAI AR program or public health laboratory for further recommendations. In the situation of high SRIR with a relatively low pSIR for the respective organism, this could signify an opportunity for antimicrobial stewardship. Overuse or misuse of antimicrobials creates unnecessary selective pressure for certain AR phenotypes. Review the rate and appropriateness of the antimicrobials that could potentially create that selective pressure for the phenotype with high SRIR. For example, review your vancomycin use if you see a VRE high SRIR. For those who submit data to AU option, don't forget to review the standardized antimicrobial administration ratios, or SARs. In this example of VRE, review the antibacterial agents predominantly used for resistant gram-positive infection SAR category. Here, we break down by steps to help you differentiate possible explanations and responses. In the situation of high SRIR or pSIRs, first, check culture utilization and specimen collection technique in your facility, especially in the locations that had high number of events. If overuse of cultures or inappropriate specimen collection technique, move to establish or reinforce your standard procedure for specimen collection and transportation. Step two, identify possible shared source of infection and any opportunities for targeted infection control. Check whether those infections are from a single strain, which may indicate a common source or route of transmission. However, whether a common source or a common strain is identified, since the rate of infection is already higher than the national baseline, we still recommend the facility investigating potential causes and consider infection control interventions. Step three, if SRIR is high with a relatively low pSIR, this means there is a high proportion of drug-resistant isolates. This is possibly caused by a selective antimicrobial pressure in your facility. In this situation, we recommend reviewing antimicrobial use, including rates and appropriateness for relevant antimicrobials. In a scenario of low SRIR or pSIR, we want to make sure that these are true low values. We recommend these 3 steps to verify. Step 1, ensure all eligible culture positive events are reported. Step 2, make sure the low number of events are not because of culture being replaced with molecular or rapid diagnostics. And step 3, make sure low number of the resistant events were not just because the drugs to determine the phenotype were not routinely tested or reported. In this flowchart, we provide detailed steps to differentiate low SRIR and pSIRs. In the situation of low pSIR, first compare EHR and AR option events. If missing AR events, check with your vendor and verify your pathogen terminology mapping. If no AR events were missing, check with the lab and see if cultures are skipped or replaced by other tests. After making sure data were not affected by any of these data quality issues, then you can determine your pSIR is truly low. In the situation of low SRIR, compare your EHR and AR option reporting. If missing antimicrobial susceptibility results for certain drugs, check drug terminology mapping with your vendor. Otherwise, check the % tested for pertinent antimicrobials if the drug were routinely tested in your lab. However, the results were not shown in your EHR. It is likely that your facility has selective or cascade reporting. In this case, work with your IT and surveillance vendor to obtain an upstream data source before data suppression. If the drugs were not routinely tested in your lab, we recommend that you disregard this SRIR. After making sure the data were not affected by any of the data quality issues in this flow chart, then we can determine your SRIR was really low. Next, I'll turn it over back to Virgie.
Thanks, Sho. The SRIR report or the pSIR report may help facilities identify potential increases in rates of infection. If the SRIR for a drug-resistant pathogen is higher than expected, facilities can run a line list to further investigate the infections and identify potential clusters. We'll walk through an example using fictitious data of how the SRIR report can be used to identify potential clusters. For example, let's say we ran the SRIR report for a facility by year. The facility notices that 19 hospital-onset vancomycin-resistant enterococcus isolated from urine specimens were reported in 2021. The SRIR for VRE in urine specimens for 2021 was 6.323, which is incredibly high and was statistically significantly different. In NHSN, we can run a line list report to gather more information on these 19 AR events. Click Analysis, go to Reports, and then in the Antimicrobial Use and Resistance module folder, click the Antimicrobial Resistance Data folder. Select a report line listing all antimicrobial resistance events and choose Modify Report to customize your line list. To filter the data by time period, choose the Time Period tab at the top of the modification screen. To display data for 2021, select specimen date year with a beginning date of 2021 and an ending date of 2021. Next, we want to filter to just hospital onset isolates identified from urine specimens. So select specimen group as a variable and use the equal operator. Use the drop-down menu to select urine. Select onset as another variable and use the equal operator, and then select healthcare facility onset. Then we will click Export to export the data into Excel. In the export, I further filtered to all enterococcus isolates that were resistant to vancomycin. I took a look at the specimen collection dates and the locations within the hospital where the specimens were collected. Hospital onset VRE in urine specimens were reported from the facility's surgical critical care unit, which is ICU-A, the medical ward, which is med ward, medical surgical critical care, MCICU, and neonatal critical care level 2-3, the NICU. All 19 specimens were collected within 5 days of each other from January 2nd through January 5th, 2021. With this information, the facility can review information about these patients in the electronic health record and determine if there were commonalities between them, including shared staff, shared equipment such as devices, or other factors. For resources, our guide to the SRIR and the pSIR is forthcoming. We're hoping to get it through the CDC clearance process, so we hope to get that posted very soon. We do have SRIR and pSIR quick reference guides that are available to help users run and modify these reports. We also linked to last year's training session, the video and the slides that discuss in depth the SRIR and the pSIR models and the methodology. And the AUR module protocol is also linked here.